I'm Chelsea Dale, and this is my presentation of an analysis of a quality initiative. For my project, I chose to utilize the Donabedium model, which I will explain further on the next slide. I chose the Donabedium model for a few different reasons. First, there are 3 easy steps that are easy to use and organize. The first step is structure. This includes the facility, the available equipment, human resources, and the overall structure of the practice. The second step is process. This includes things like treatments, diagnosis, resource requirements, and overall process of care. The third step is your outcomes. Things measured in outcomes include mortality, morbidity, cost, factors creating costs, quality of life, and overall satisfaction. The Donabedium model is a great tool for healthcare as it allows us to easily conceptualize the issues leading to poor outcomes and hopefully make positive changes. The issue I identified while shadowing my nurse practitioner was a poor handoff between clinicians. While the nurse practitioner was covering urgent care during the other provider's lunch, a primary care doctor sent a patient to urgent care for a high potassium level. No lab value was reported, and the patient was confused why he was sent to urgent care. The nurse practitioner did not know what was expected of her. She had to make phone calls to the primary care doctor's office and ultimately walk to that side of the building to speak to him directly. She had to redraw his labs, which showed a normal potassium level. We speculated the first sample was high due to hemolysis, but if it had been truly high, she would have had to make yet another transfer of care to the emergency room. A proper handoff tool could have avoided wasted time and cost for the patient. He also left feeling unsatisfied due to all the confusion and the lengthy wait. This ordeal also put the APRN behind on her regular scheduled appointments. Standardized handoff tools are essential to patient safety. The Joint Commission states, the primary objective of a handoff is to provide accurate information about a patient's care, treatment, and services, current condition, and any recent or anticipated changes. The information communicated during a handoff must be accurate in order to meet patient safety goals. Another article published by the Joint Commission states, the Joint Commission's Sentinel Event Database includes reports of inadequate handoff communication causing adverse events, including wrong site surgery, delay in treatment, falls, and medication errors. A study released in 2016 estimated that communication failures in U.S. hospitals and medical practices were responsible for, at least in part, for 30% of all malpractice claims, resulting in 1,744 deaths and $1.7 billion in malpractice costs over 5 years. Team STEPS stresses the importance of necessary steps to take regarding a change project. First step is establishing a sense of urgency. Second is forming a powerful guiding coalition. Third is creating a vision. Fourth, you communicate the vision. Fifth is empowering others to act on the vision. Next is planning for and creating short-term wins. Next, you consolidate improvements, but still producing more change. And finally, you institutionalize your new approach. I will break down Kotter's 8 steps in relevance to my change project. The first step is establish a sense of urgency. First, you need to help the office staff understand the need for a change regarding the handoff. The next step is to create a change team and delegate responsibilities between staff members. The next step is to explain the end goal and benefits of a standardized handoff tool. Then you can even draft a standardized handoff tool using your change team. Step 4 is to communicate your change vision. Try to gain buy-in from your staff members. You can humanize the project by providing the example about the hyperkalemic patient. The fifth step involves empowering others. For this, you need to remove barriers to success. Barriers can include negative employee attitudes, limited understanding of the change and its impact, failure to involve employees in the change process, resistance to organizational cultural shift, lack of resources, and lack of management support for the change. Next step is planning for and creating short-term wins. You can start by celebrating small victories such as better staff communication, time and money saved, less patient confusion, and other positive changes seen. The next step is to consolidate improvements and producing even more change. Finally, you institutionalize your new approach. This involves implementing official policies regarding the new handoff tool and having new employees teach new hires this process. Team Steps discusses a handoff tool called the S-bar. The S-bar includes 4 steps. S stands for situation. What's going on with your patient and why are they being transferred? B stands for background. This includes pertinent background or medical information. A stands for assessment. This is my own clinical judgment of the patient. R stands for recommendations. This is asking what can you do for my patient now that they're being transferred. Now I'm going to use the Donabedian model to break down my change project. According to the IHI, it's important to name the targeted office area, size of the office area, assess the number of staff within the office area. I shadowed in a large medical office building that included a primary care, an urgent care, podiatry, pediatrics, a lab, and an imaging department. Within the primary care office and the urgent care office, there are about 10 patient rooms. Between primary and urgent care, I saw about 4 to 5 physicians, several nurses, and administrative staff. Within the structure component of the Donabedian model, there is also a lack of a standardized handoff tool used between providers and clinical staff. Now for the process component of the Donabedian model. Our first step is to develop a handoff tool. For this purpose, we're going to use the S-bar. Team Steps recommends selecting a multidisciplinary change team. This can include members of staff including nurses, providers, and other administrative staff. By doing this, you're ensuring representation from different leadership levels. Once you have your handoff tool identified, you can develop an implementation plan timeline. The final portion of the model is the outcome. Team Steps recommends assessing for patient outcome measures as well as clinical process measures. Patient outcome measures can include decreased repeat lab draws and radiology orders, and increased patient satisfaction survey scores. Clinical process measures can include length of patient wait time, number of required patient appointments made and completed, percentage of lab results communicated to patients, provider efficiency, which includes time saved with less go-between asking questions and less charting after hours.